Assalamu alaikum, everyone, and I just welcome you all to our day 1 session of ABGs Made Easy. I'm Dr. Sadaf, and I think we should start now. Okay, so ABGs present the doctor the 6 numbers that needs to be interpreted as one result. ABGs tell us about the activity in two systems, that the respiratory system and the metabolic system, and then further respiratory system gives us uh, some information about the oxygenation, and the other thing is the ventilation. Either it's in order or it's out of order. Both these systems, the respiratory system and the metabolic system, these are primarily concerned with keeping the blood pH in the normal range. So when one system is out of order or not working sufficiently, the other system will start compensating for the deficiency to keep the environment steady and maximally normal. Okay, these are the normal values of the ABGs. Let me use the pointer. Okay, so we take 7.4 pH as the average, the mean value, and when the pH goes down below 7.35, we call it acidosis, and when pH is above 7.45, we call it as alkalosis. Now about this, when PaO2 is below 80, we call it hypoxemia. And about this, when PaCO2 is below 35, we call it hypocarbia. And when PaCO2 is above 45, we call it hypercarbia. And about this, the bicarb levels, we take 24 as the mean or average value, and we write it down like this, 24 plus minus 2. And about these, some ABGs machine have slots for different kind of parameters, like for example, electrolytes, sodium, potassium, calcium chloride. Some ABGs machine even give you information about the glucose and the serum lactate levels. That is very important for the patient of shock and for the septicemia. Few ABGs machine have HP, the option for HP, and few ABGs machine give you information about HCT, that is basically the hematocrit levels. Some ABGs machine can also give you P50 value, and then there is the AA gradient. AA gradient is this. And then some ABGs machine can also give you information about PF ratio. A PF ratio is partial pressure for oxygen, and F is FiO2. So these are important for the respiratory illnesses and respiratory pathologies. Okay, now coming to the very basic of basic base abnormalities, I will just quickly go through this slide because most of you already having the basic knowledge about the acid-base disturbances. So I will just quickly go through it. Now, when you have an ABG report, you have look for pH. Either it's if it's normal, then good, but don't take it just literally because sometimes the normal is not normal. I will explain it later. So pH, either it's low or either it's high. If it is low, you know it's acidemia. And when it is high, pH is high. High means it's more than 7.45. I have to use the other pen. High means it's more than 7.45. Okay. And low means it's below than 7.35. So it's acidemia. And when pH is high, it's alkalemia. Now, what is causing acidemia? Either there is increase in acid production or decrease in the alkali in the blood. So acid production is maybe PaCO2, that is, we also call it the respiratory acid, respiratory system acid, PaCO2. So either the acid is high or bicarb is low. If the acid is high, we call it respiratory acidosis. The respiratory acid, okay? We call it respiratory acidosis. And when the alkali is low, as you all know that bicarb is alkali. So when the alkali is low, we call it metabolic metabolic acidosis. Now, coming to the other side, when there is alkalemia, or you can say the alkalosis. So what happens here? Either the acid is low or the alkali is high. So when the acid is low, because it is a respiratory acid, we call it respiratory alkalosis because it is respiratory problem. And in case of bicarb, when the bicarb is high, or you can say the alkali is high, we call it alkalosis, and it is known as metabolic alkalosis. Anything related to bicarb will be metabolic, and anything related to PaCO2 will be respiratory. Now, their compensation, how these are compensated. First of all, these systems will be compensated by their parallel systems, or you can say the opposite system. Respiratory system will be compensated by the metabolic, and the acidosis will be compensated by alkalosis. Let me clean the slide. Now, when there is respiratory problem, metabolic system will compensate for it. How? Respiratory acidosis will be compensated by the opposite. What is that? Metabolic alkalosis. Metabolic acidosis, it will be compensated by its opposite. Metabolic part will be compensated by respiratory, and acidosis will be compensated by alkalosis. And same goes here. Today, we will discuss the metabolic system, and mostly I will discuss the metabolic acidosis, the main part, and the further I will elaborate the anion gap and how to calculate anion gap. Now, we have abnormality of metabolic acidosis here, and then we have abnormality of metabolic alkalosis. Now, as I have already mentioned, and as most of you know, that metabolic acidosis means there will be some problem with the bicarb. And acidosis means alkali is low. So bicarb will be low in metabolic acidosis. And in metabolic alkalosis, it will be reversed. Like metabolic, there is bicarb. And what is alkalosis? Mean it is high. Now it's compensation. As I have mentioned earlier in the previous slide, that metabolic acidosis will be compensated by its opposite system. That is respiratory system. And how it will compensate? By hyperventilating. Now, if bicarb is going down, PaCO2 will also go down. How and how much it will go down? How much it will decrease? PaCO2 will decrease 1.25 millimeter of mercury mmHg for each 1 millimole decrease in bicarb. Let me write it down for here. Like for 1.25 decrease in PaCO2 for 1 millimole of bicarb. 1 millimole of bicarb. All right. Now, what's happening here in the metabolic alkalosis? For every 1 millimole decrease in bicarb, there will be, for every 1 millimole increase in bicarb, PaCO2 will increase by 0.75 mmHg. And I will write it down here. 0.75 mmHg for every 1 millimole of bicarb, it will increase. Now this is the compensation. Now we have to see if this compensation is adequate or the system is overdoing or system is underdoing. When one system is compensating for the other, like for example here, for metabolic acidosis, respiratory system is coming in action, and it's started compensating for metabolic acidosis to keep the pH normal. So what's happening here? We have to see that if the system is working within the range, within the limit, either it's overdoing, it's underdoing, or it's doing its proper function. And for that, we need a formula. I will share that. This one. This is used for metabolic acidosis. We will use this formula, expected PaCO2. Just take a screenshot or write it down, because it's going to be coming to be in use for the upcoming slides. just take a screenshot. We will use this formula to see if the compensation is adequate or not. Now, what's happening here? We have to see that if lower than expected PaCO2 means we will get a report of ABGs and we will see that what is the value of PaCO2. If the PaCO2 is below the expected CO2, we will call it superimposed respiratory alkalosis. I will write down some values and then you will understand. Let's say, for example, bicarb has reduced from 24, it's going down and it's 16. And same, PaCO2 has to decrease to compensate. Now let's say for 16, PaCO2 has been decreased to, let's say, 25. We get this value from the ABGs. By applying the formula, let's say we get a value of 25. So we will say, yes, it is adequate. But if we get a value of 20, lower than the expected, we will say the patient is having respiratory alkalosis. And if we get a value of 30 after applying the formula, higher than the expected, we will say the patient is having respiratory acidosis. So this is the formula which we use to get the expected value, and then we have to match it with the report of the ABGs. Now, these are the two types of the metabolic acidosis. One is the on this side, it is the metabolic acidosis where the anion gap is increased. And this is the metabolic acidosis where it is the anion gap is normal. What is anion gap? I will just describe it and elaborate it for you in my next slides. These are the different reasons of the two different types of metabolic acidosis. You can take a screenshot, and well, this is also available on the internet and in the books everywhere. By just simply calculating the anion gap, you can make a diagnosis, or at least you can just rule out so many different causes of metabolic acidosis, and thus it may narrow down or it may shortlist the causes, and then you can easily reach the diagnosis. These are the normal value of the anion gap. The normal value ranges between 8 to 16. Now, about the metabolic alkalosis, these are the different causes of the metabolic alkalosis. The main thing I want to tell you is this one. Let me highlight it. Now, measuring the urinary chloride may be helpful if the cause of the alkalosis is not evident. If it is low, less than 10 millimole, when the alkalosis associated with volume contraction. But the urinary chloride may be high, more than 20 millimoles, when the alkalosis is due to hyperadrenocorticoidism or severe potassium depletion. So on the basis of urinary chlorides, you can also rule out so many different causes, and it may narrow down the different causes of the metabolic alkalosis. Now, about the anion gap. Okay, now what is anion gap? There are different types of electrolytes and ions in our body, mostly the positive charge, and then there is the negative charge. Positive charge known as cations, and negative charge are known as anions. These are the cations, and these are the anions. Let me tell you first about the cations. Now we have sodium and potassium as the positively charged. Now, in the recent guidelines and updates, this potassium has been removed from the anion gap. So we will just take sodium. There are some unmeasured cations. These are the measured cations, and these are the unmeasured cations. There are the anions that are measured, and those that cannot be measured, or that are not measured actually. This measured and unmeasured is actually is not is don't take it as in literal meanings, because unmeasured, the term we are using here is a misnomer. Okay. Okay. So this is a misnomer, because because among these unmeasured, the so-called unmeasured, calcium, magnesium, and so many proteins can be measured, but we don't include these cations or these anions to calculate the anion gap. So that's why we just keep them out, and we just take sodium, bicarb, and chloride. This is the anion gap. This is unmeasured anions, and this part is actually formed by the unmeasured cations, and the difference between the two is an ion gap. In some conditions, in some pathologies, in some metabolic disorders, this part started increasing. These, okay? I hope you can see the cursor moving here. The unmeasured anion started increasing in the blood, which causes increase in the anion gap. Now here it is mentioned 8 to 12, but in the latest guidelines, it's 8 to 16. Now, this is a normal status. Anion gap is normal. Now, as you can see, the anion gap is normal here as well. These both are at the same level. This is normal anion gap, and it is a metabolic acidosis with normal anion gap. Now, this metabolic acidosis is with high anion gap. High anion gap means, can you see? As I have mentioned previously, unmeasured anions started increasing in the body, which will further go down, and this difference between the two, you can see, this lies here and this lies here. So the gap has been increased, as you can see. While here it is this, and here it's increased to this. So this is known as high anion gap, and this is known as normal anion gap metabolic acidosis, and this is high anion gap metabolic acidosis. About hypoalbuminemia. What is the link of hypoalbuminemia with the anion gap? Normally it's about 11 millimole of the anion gap is made up by the albumin, a negatively charged protein, the anion. If you remember that a 50% reduction in albumin concentration reduces the anion gap by about 6 millimoles, so it is easy to estimate the effect of albumin on the anion gap in most ICU patients. So albumin is very important when you are calculating the anion gap. So now about anion gap and the role of albumin in it. This is the formula when we are calculating anion gap, and then we have to subtract the albumin from it. If the value of albumin is provided, then you have to subtract it to adjust to adjust the value of the anion gap. Let's say now what you have to do is, what is 14? It's a measured anion gap. The measured means which you have calculated already. You have measured it. This is formula. This is 1.5. 1.5 is, it is the albumin, the serum albumin. Now we have subtracted it, and we have multiplied it with 2.5. We get 6, and it's 20. So this is the adjusted anion gap, also known as adjusted anion gap in the face of hypoalbuminemia. When there is hypoalbuminemia, you can use this formula to adjust the anion gap. Okay. Now I have one example. I have few exercises for you today, and I need your active participation. Now tell me, now just look here. We have pH of 7.32. What is this? Just tell me, is this acidemia or it is alkalemia? Or what do you call is acidosis or alkalosis? Just inbox me. Acidosis. Yes, this is acidosis. Okay. Yeah, this is acidosis. Good, 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 good. Now, we have to see its acidosis is due to respiratory component or it is due to metabolic component. Now, kindly tell me, it is metabolic or it is respiratory. Okay, Adnan, yes, it is metabolic. Metabolic. Yes, this is metabolic. Okay. Yes, good. Now, we will see that this is metabolic. Now, first of all, this is acidosis. Then we have to see what is the cause of acidosis. It is metabolic acidosis. Yes, okay. Now we have to see the compensation. The compensation is adequate, it is overdone, it is underdone. The formula was, you all know, this is a formula. One thing is missing here. It is plus minus 2. This was missing. Now, use this formula and tell me, this is the compensation is adequate, or it is alkalosis, or it is acidosis, respiratory alkalosis or respiratory acidosis. Now use this formula, calculate it. I'll help you. 1.5 multiply with, what was the bicarb? Bicarb is 14. 8 plus minus 2. Now you have to multiply 1.5 and 14. Equal to 21. Now it is 21. You have to add. Now it will be 29. We have here plus minus 2. Plus minus 2 means it will range between 27 to 31. So this is the expected PaCO2. And what we got here, we have 28. So tell me, what is it now? It is compensated or what? Yes, Aruj, Adnan, compensated. Noman, compensated. Yes, this is compensated. You all are right, because it's lying in the range. Let me clear it and let's see the results. So it's appropriately compensated. Now you have to calculate the anion gap. Whenever there is metabolic acidosis, you always have to calculate the anion gap. Now kindly calculate the anion gap. You have 140 sodium. The chloride is 116 and we have 14 is the bicarb. Now kindly calculate it. You have to do it like this. 116 plus 14. Okay. It is oh, I got 10. So what did you get? You're saying it's normal anion gap. Okay. I don't know. My maths is good, is not that good. So we have, okay, I was right. It's 10. And yes, this is normal. You all are right. Very good. Well done. So this is metabolic acidosis that is appropriately compensated, and the anion gap is normal. Well done, everyone. Now let's move to the next slide. Now you have to see this and kindly tell me what is the disorder and what is causing this disorder. Okay, metabolic acidosis. Yes, you're right. We'll check for CO2. This is metabolic acidosis. Now you have to see its compensation. Now kindly look for the compensation. Let me do it with you. 1.5 multiply with 12. And then we have 8. And then we have plus minus 2. Now 15 multiply with 12. Now multiply it. Okay, this is 18. This is 18. 18 plus 18. 18 plus 8 is equal to, it is 26. And this is plus minus 2. So this is in. Now tell me. It's compensated. Well done. Yes, it's compensated. The name D. What's your actual name? Because it's difficult to call you D. Your answer is correct, Dr. D. It's compensated. Ali, you're right. Compensated. Adnan, you're also right. It's compensated. Pradeep. Okay, you're Pradeep. All right. How are you, Pradeep? Adequately compensated. Saima Batul, yes, you're right. This is adequately compensated. Jennifer, you're not answering. Okay, good. It's good to see you. Pradeep, it's really good to see you. And Jennifer, you're not answering. Okay, this is compensated. Well done, everyone. Great. Now tell me, what is the anion gap? Now calculate the anion gap. Adnan is saying 22. Okay, this is, let me write it for you. This is 128, then minus 94 plus 12. Now you have to calculate it. 94, this is 6. And this is 128. This is 22. Yes, you all are right. It's high anion gap. Exactly. Well done. Very good. So this is a high anion gap metabolic acidosis that is appropriately compensated. Let's go to third example. Now we have 58 years old man with diabetes and CKD, and it presents with abrupt onset dyspnea in 2 hours. Now these are the values. Now you have to see. pH is 7.47. This is, what does that show? Now what does that show? It shows that respiratory alkalosis. Okay, you're saying respiratory alkalosis. So we will go and see what is this. Very good. This is alkalosis and this is respiratory alkalosis. Now you have to see the compensation. We have 20. For every 10, it is 2. For a decrease of 20 mmHg of PaCO2, there should be a 4, decrease of 4 millimole of bicarb. So this is the expected one. This should be like this. But what we are having here is bicarb is 14. That is below the expected value. So it will be, so what is this? Now tell me. Now everyone is silent. Now, come on, tell me, this is associated metabolic acidosis or this is metabolic alkalosis? Okay, Jennifer, very good. Jennifer has rightly answered. It is metabolic acidosis. So we will move to our next part. That is, now as we have identified that patient is also having metabolic acidosis because the metabolic system is overdoing. So because the metabolic system is overdoing, so bicarb has decreased and patient has developed metabolic acidosis. Now, when there is a metabolic acidosis, what we have to do? We have to calculate or measure the anion gap. Okay. Now you have to calculate the anion gap. 7. That is actually normal. So the patient is having respiratory alkalosis with normal anion gap metabolic acidosis. Okay, you got it? So we will go to our next slide. Our next slide. Now kindly solve it. 48 years old woman is found to be unconscious next to an empty pill bottle at home. This is the pH. And these are the values. First of all, this is metabolic acidosis. Okay, yes. Now you have to calculate, now you have to see the compensation. For compensation, you have to apply the formula. And this is not appropriate. I have already calculated it for you. So let's go to the PaCO2 is higher than expected. How come? Let's do it ourselves. We will do it ourselves. The formula is, we will multiply 1.5 with bicarb. So we will have 15. Now we have to add 8 and we will get 23. Okay. This is the expected value. Okay. This is the expected value, 23. What we are getting here is 34. This value is more than the expected value. This value, 34, is higher than the expected value. So that means patient is having higher than expected. Patient is having respiratory acidosis as well. Yes, Ali, you're right. This is metabolic acidosis with respiratory acidosis. Yes, you're right. Jennifer, it's not adequate, dear. This is patient is having two disorders at the same time. Patient is having metabolic acidosis, and while the respiratory system was compensating, but respiratory system is unable to compensate. So the CO2 value is higher than the expected. So we will say the patient is having metabolic acidosis as well as respiratory acidosis. Now you have to see the anion gap. Now this is the anion gap I have already calculated. Now someone is saying, okay, now MS Khan is saying it is the non-anion gap. Okay, now this is a tricky part here. When they have mentioned the albumin, you have to readjust the anion gap. And what was that? We have the formula. This is the formula. We got here elevated anion gap or high anion gap metabolic acidosis plus respiratory acidosis as well. Now, about the osmolality and osmolar gap, I will just briefly show you the formula and what is the osmolar gap and what is the double gap. Basically, these are some terms I want all of you to know. This is a formula where we calculate the plasma osmolarity. This is 2 multiply sodium and glucose. We need the value of sodium. We need glucose here to calculate the plasma osmolarity in BUN as well. Now, osmolar gap is actually the difference between the measured osmolarity and the calculated osmolarity. As you all know, calculated is what? This is how we calculate it. Okay. Now, what is a double gap? When the patient is having high NN gap metabolic acidosis plus osmolar gap, the raised osmolar gap, then we call it double gap. Plasma osmolarity, the formula has been given again. This is the normal plasma osmolarity range between 275 to 295. About delta gap, we will describe, I will elaborate it tomorrow. Feedback in my group. And if you want to ask anything, you can also post your question in my group. Okay. Thank you so much. See you tomorrow. All of you tomorrow on the same time, 9 p.m. tomorrow, inshallah. You can also share the link with your friends. Thank you so much, Aruj. Thank you, everyone. Thank you so much. Okay, take care, everyone. See you tomorrow. Okay, Allah Hafiz. Bye.